Welcome everyone. Thanks for joining us today where we'll talk about repositioning from diabetes educator to diabetes care and education specialist. If you would like to ask a question during the presentation, feel free to type your question into the Q&A box at any time, and we will answer as many questions as possible during the Q&A session at the end of the presentation. So we have with us today Karen Kemmis, AADE's 2019 president. So I will turn it over to Karen to get us started.
Hi, I am so pleased to present this webinar today. I'd like to start by welcoming everyone and to really thank you for taking time out of your busy workday to be with us. Today's conversation marks a significant milestone in our specialty's history. It is my pleasure to share the work of the board in exploring the name of our specialty. With me today, we have several guests who have worked closely with the AADE board in this exploration. Please welcome Chuck McFarland, CEO of AADE, Cheryl Traficano, CEO of NCBDE, Diane Beecher, who is the CEO and Senior Strategist with the Brand Consultancy, and Jen Layton, the Chief Research Officer with the Brand Consultancy. What's in a name? At its core, this is a question the AADE board set out to answer. As we came out of our vision work and began to implement Project Vision, we realized that the name Diabetes Educator needed to be evaluated. The term Diabetes Educator, when applied to our specialty, carries with it our proud professional history, as well as the weight of a changing healthcare environment. For those of us who have dedicated our careers to this specialty, it is at once our professional identity, it's a description of our knowledge, including our skills and experience, it's our professional brand. However, it's also a term that can narrow the focus of our work. We are a very heterogeneous group. AADE's most recent estimate is that there are approximately 30,000 professionals within the diabetes education specialty. We have multiple specialties, including nurses, dietitians, pharmacists, social workers, exercise and rehab specialists, and that's just to name a few. There's about 20,000 certified diabetes educators, or CDEs, and about 1,100 people have their board certification in advanced diabetes management, or their BCADM. You may not realize that approximately 55% of AADE members do hold a credential, the CD or the BCADM, and 45% hold no diabetes-specific credential for various reasons. We are really pleased that so many find value in their membership in our organization. Today we will walk you through the decision-making process so you have an understanding of our process rigor. We'll look at the impetus to look at the specialty's name, the process of research and stakeholder engagement. We'll then review the data gathered and how this shaped our decision-making. We'll announce the outcome, look at next steps, and have time at the end for question and answer. In many respects, the AADE board's exploration of the specialty title is rooted both in the healthcare environment and societal changes. Healthcare is in a state of dynamic change that ranges from integration of technology to new models of care, changing systems of payment, and focusing on outcome measures. It reflects changes in consumer expectations about the way they engage in their health, as well as how we all seek and then consume information and care. It also reflects the challenges of access, adequate reimbursement, and shifting payment systems. When faced with this ongoing environment, AADE has chosen to be a driver of the change rather than the passenger. Over the last year, AADE's board has shared its vision for the specialty through Project Vision. We are now putting our vision into action. Our vision's 6 pillars define the knowledge and skills our members must demonstrate to remain relevant. The pillars are driving the integration of diabetes clinical management, self-management education, prevention and support, the integration of cardiometabolic and related conditions, leveraging technology-driven diabetes care, education, and support, the promotion and integration of behavioral health, the optimization of diabetes care delivery for the quadruple aim, and advocating for equity to person-centered care. I hope by now that you are aware of the vision for this specialty and consider it in the light of your own professional strengths and areas for development. If you have not, I encourage you to go to diabeteseducator.org for a more detailed summary of Project Vision. One lingering theme that came out of our Vision stakeholder engagement was that our members do so much more than education. It was clear that the name of our specialty does not completely reflect the work we do and the value we provide. In some ways, it limits stakeholder understanding of our roles. With that consistent and lingering theme in mind, the board set out to explore how effectively the term diabetes educator serves our members and people with diabetes. The goal of our effort was in part to determine how well it reflected the critically important role we play on the care team. In March, the AADE board engaged the brand consultancy to guide our repositioning discussion, including an overview of what a brand is, research, data, decision points, and brand story. It is my pleasure to introduce the brand consultancy team to walk us through our due diligence on identifying a new name for the specialty. With us today are Diane Beecher, CEO and Senior Strategist, and her colleague Jen Layton, the brand consultancy's Chief Research Officer.
Thank you, Karen. So our specialty is our brand. As we initially approached this initiative, we approached it as if we would a brand. Why? Because, as Karen mentioned, our specialty is our brand. We define brand at the brand consultancy as, as our reputation. Jeff Bezos from Amazon has said it best. Your brand is what people say about you when you're not in the room. In other words, your brand is what you stand for in other people's minds that enables you to stand out as unique and different, to stand out as uniquely you. So it's really what you say about yourself, but more importantly, it's what others say about you. It is their expectations about engaging with you before they do so, and the sum of the experiences they have with the people, with the products and services, and the processes that represent your specialty. So our process for how we position the specialty. We first did our due diligence to understand the entire market landscape. We then conducted in-depth phone interviews with key stakeholders. And finally, we conducted rigorous quantitative research with both members and prospective members. For our in-depth phone interviews, we talked to key stakeholders in regulatory, in payers, sister associations. You'll see the specific organizations listed in that left-hand column. For our rigorous quantitative research, we interviewed over 500 members, non-members, and persons with diabetes or pre-diabetes. You'll see the specific professional roles listed in the right-hand column. What we initially found out was that the term diabetes educator doesn't convey everything you do today. The dark green on this chart shows the services most associated with a diabetes educator. Across both professionals and persons with diabetes, you see a strong association with healthy eating, exercise, medication management, glucose monitoring, problem solving, healthy coping, and even reducing risk. However, when you look at the yellow and pink, there's a very low association of diabetes educator in terms of preventing, detecting, and treating acute and chronic complications, along with providing that critical psychosocial support. the existing title does not fully convey the important role you have as part of that integrated care team and the critical services you do provide today. This was our first indication that we should consider exploring additional titles that might better capture that full spectrum, again, of that important role you serve for persons with diabetes. So we tested 10 new titles, potential titles for a specialty, along with the existing diabetes educator. Here is the list we tested. You'll notice a broad mix of titles that include what you do and who you are. So think about that combination that you see here in terms of education, care, of what you do, and then who you are in terms of a specialist, a manager, an educator. And we looked at, as I said, various combinations of who you are and what you do. We showed each respondent a full description of exactly what a diabetes educator does today. Then we asked them to tell us which title they thought should be used that truly encompasses everything you do. And you'll notice all the specialist titles were in the top tier. However, diabetes care and education specialist was significantly more preferred by both healthcare professionals and persons with diabetes. Diabetes educator, as a title, sits in the middle of preference. This is not surprising. We just walked through that diabetes educators weren't being associated with all the services we provide today. So that connection wasn't being made. And this pattern generally held across all professions, even among current diabetes educators, which you see in that middle column of the table. It was also important for us to understand what each of these titles conveyed in terms of critical attributes that we want the specialty to be known for. So up until this point, we knew the current specialty title of diabetes educator didn't quite convey that full spectrum of what you do, and we knew diabetes care and education specialist was the most preferred title to encompass that entire role in the diabetes care team. However, we also needed to understand how well each title conveyed those critical attributes, again, that we want to be known for. And you'll see the critical attributes are highlighted there in blue font. All great things in terms of what diabetes educator conveys today. So look at, you'll see it conveys that we are knowledgeable, we're a coach, we're a mentor, supportive, we're patient-friendly, and we provide person-centered care. All great things. However, when looking at the critical attributes, we see the title doesn't convey necessarily a trusted preventative specialist who's integral to that overall care plan. On the flip side, diabetes care and education specialist is the title that most strongly conveys these critical attributes. And if we move on to the next slide, you'll see that this pattern continues. Again, you'll see that the title diabetes educator underdelivers on some of these critical attributes, whereas diabetes care and education specialist is incredibly strong. So look at expert, collaborative, comprehensive, outcome-oriented, and forward-thinking. Again, all attributes we want the specialty to be known for. Diabetes care and education specialist is delivering very strongly on conveying those key critical attributes, whereas diabetes educator was under-delivering, again, on those key attributes. Up to this point, we had a clear indication that diabetes educator was not fully conveying what we needed it to convey in terms of scope of services, critical attributes, and our critical role on the diabetes care team. But to truly determine how the specialty compared to the others we tested, we pulled all that data together into one snapshot. The left column represents the evaluative criteria a title has to deliver on to accurately reflect everything we do today and our role in the continuum of care. The specialty title we choose has to fit with the overall description of services we provide. It also has to convey that we provide comprehensive and person-centered care, that we are integral to the overall care plan, and that we are seen as an expert and collaborative. Diabetes Care and Education Specialist significantly outperforms all other titles, including Diabetes Educator. In keeping your eye on the colors again, you'll notice one title that most strongly delivers on each of our evaluative criteria, Diabetes Care and Education Specialist. So to quickly summarize the data we just walked through, the data told us the specialty of Diabetes Educator conveys a knowledgeable and supportive advocate and coach who provides patient-centered education to people with diabetes. All right and true. But repositioning the specialty to Diabetes Care and Education Specialist not only more accurately conveys what you do today, but also elevates the importance of your role. Repositioning the specialty to a Diabetes Care and Education Specialist conveys a compassionate teacher and expert who, as an integral member of the care team, provides collaborative, comprehensive, and person-centered care and education to people with diabetes.
And so moving forward, AADE will begin to refer to those working in the specialty as Diabetes Care and Education Specialists. It reflects our work and the value our service provides. And thank you so much, Jen, for walking us through those data that really helped to support this decision. For the next few minutes, we'll talk about the topics that have generated the most questions since the specialty change announcement. We'll touch on our role within the care team, the impact on job title, on pay, credentialing, including the CDE and BCADM. I encourage you to promote your role as a key member of the care team. This is a way of repositioning within your job. Your job title will not necessarily change. AADE will be providing you with a toolkit to help as you share this information with your employers, referring providers, people with diabetes, and others that may have questions about the repositioning of the specialty. This does highlight your specialization, so it may impact your job description. And wouldn't it be nice if that translated to higher pay? But that will obviously be individualized by your employers. When we look at scope of practice, this does not change your primary scope of practice. That needs to be determined by your primary professional license, and that will vary by your state licensing board as your employer. For example, as a registered nurse in New York, there's a certain scope of practice driven by the education department that allows me to do particular things. An advanced practice nurse in a different state might have a different scope of practice. A registered dietitian will have a particular scope of practice, and again, this really varies state to state. So this does not change with this retitling of the specialty. What about my certifications? Impact on credentialing, including the BCADM and CDE. Certifications will continue to be an excellent way to demonstrate your knowledge and abilities in diabetes care and education. So where before I might have referred to myself as Karen Chemist, credential, CDE, diabetes educator, now I would refer to myself as Karen Chemist, credential, CDE, diabetes care and education specialist. I'm sure that some of you may be wondering what will happen with your BCADM credential and if you'll have to take another exam. That's the big question. Let me assure you that you will not have to retake the BCADM exam, and BCADM will continue to be an excellent way to just demonstrate your competency in advanced diabetes management. Now I'll ask Cheryl Trafficano, the CEO of the National Certification Board for Diabetes Educators, to talk about the CDE certification in relation to the change in the specialty. Cheryl?
Thank you, Karen. NCBDE really appreciates the opportunity to be a part of this webinar today. We know that there can be confusion between NCBDE and AADE as far as their missions and functions. But it's important to remember that NCBDE is a separate and autonomous organization, but AADE has included us in the discussions related to the potential change in the specialty name throughout the review process. At this time, the NCBDE board is investigating implications of the specialty name change to the CDE program and hopes to announce a decision in the near future. A result of the investigation may include a change in the name of the certification. However, what we can definitely say right now is that regardless of the decision on the name of the certification, there is no consideration of current CDEs needing to take another exam to continue to hold the certification. Also, with AADE's project vision and the specialty change, NCBDE will be looking carefully at what diabetes care and education specialists are doing in their roles sooner than we normally plan to, in order to ensure that the exam and certification program are assessing what's happening in the field. This change may also provide an opportunity for the NCBDE board to reflect on aspects of the renewal journey. We want to ensure that those who renew their certification are staying up to date in the field. This may be where NCBDE might consider identifying a minimum number of hours, continuing education hours, in one or more defined content area, such as diabetes technology, behavioral health, or population health. But as stated earlier, nothing has been decided yet, and any changes will be rolled out with time for adapting to those changes being built into the process. We encourage CDEs to keep an eye out for NCBDE communications in the future, as well as keeping up to date with our Facebook and LinkedIn pages. Certification through NCBDE will continue to be an important avenue for demonstrating to both people with diabetes and members of the care team that you hold specialized knowledge and skills in diabetes care and education. At this time, I'll hand the discussion back to Karen. Thank you.
Thank you, Cheryl. So now I'd like to review our timeline. At AADE 19 in Houston, I had the privilege of telling those in attendance in the first general session of our retitling of the specialty. I wasn't sure about the response, and I was overwhelmed with the positive response we got. So at that same time, we conducted a stakeholder summit at AADE where we invited several leaders, volunteer and staff leadership from lots of organizations to put the word out that this is our change and to get their ideas and how this would integrate into the care team. So it was very broad-based as far as the group goes. We invited some endocrine diabetes specialty practices, including ACE and the Endocrine Society, the ADA, JDRF, and the Academy of Nutrition and Dietetics. We had representation from primary care organizations, including AAFP for family practitioners, AANP for nurse practitioners, and AAPA for PAs. People with diabetes were represented with leadership from Beyond Type 1, Beyond Type 2. We had governmental representation from the CDC with the Division of Diabetes Translation. The Helmsley Trust was there in the group, and Cheryl and some of the key volunteer leadership from NCBDE. We really went into this thinking that we wanted to get all sorts of input, any concerns that people had, and again, we were just overwhelmed by the positive response of how those in attendance thought this was going to fit into the care team. It was really a better descriptor of what we do and how it would really ultimately help people with diabetes to be able to seek out and benefit from our services. So now moving forward, in the fall we'll continue on with stakeholder engagement and level setting and support. We'll have large outreaches, including like this webinar today, and we'll work with our internal audience communications. We'll focus on our coordinating bodies, local networking groups, communities of interest, committee chairs, and really You'll see lots of information on the website. You'll see frequently asked questions. We really want to keep everybody up to date and really be there to help support in this transition. The key is how to live the brand. In January of 2020, our goal is to have a formal launch, and we will have a toolkit ready so that you can bring this, as I mentioned before, to your employers, to referring providers, people with diabetes, and other groups that are involved. Our intended audiences are wide-ranging. First and foremost, ourselves as diabetes care and education specialists. We really must ensure excellence, relevance, and embodied attributes in this specialty. Part of that is looking to how we can each expand our knowledge in the specialty, but I think if you reflect, a large part of this is being able to tell other people, this is what we have been doing, this is what we do. We want to reach out to providers to build a clear understanding of our roles and the value of our services, and critical, our audience is people with diabetes. We really want to make sure they understand the services we provide, and we want to be there to help more people. One of the biggest drivers of this is that diabetes educators are woefully underutilized, and we really want to make sure that those individuals who could benefit from our services are able to ask for this and participate. So with this, I get to share with you our brand positioning statement, which is a culmination of how we will work to reflect your roles as it moves from diabetes educator to diabetes care and education specialist. This brand positioning statement was generated from many of the surveys, including some that many of you participated in. So as you go through these words, understand that those surveys, our data collected, created this positioning statement. There you are on the forefront, understanding, preventing, treating. There's a person with diabetes right beside you, empowered, encouraged, energized. And there we are, an evidence-based organization helping you stay on the leading edge, researching, educating, and facilitating a shared purpose and a singular focus, so that together we can foster a person-centered world where thriving is a way of life. There we are, helping you connect with like-minded leaders, prove your value, and create a circle of well-being that inspires not just our organization and person with diabetes, but the future of an entire specialty. There we are, observing, as individuals are no longer defined by diabetes, but instead by an optimism that says, yes, I will live a longer, fuller life than I ever thought possible because you cared enough to lead so that my best outcomes could follow.
Okay, wonderful. Thank you all for presenting that. So right now we're going to move into the Q&A portion of the webinar today. So just as a reminder, if you do have a question that you'd like to ask, you can type it into the Q&A box on your screen. And we've already got a number of questions in, so we'll get right into it. The first question says, do you have to be certified to use the title Diabetes Care and Education Specialist?
So I'll take that. You don't have to be certified, just like with diabetes educator. Many people who don't specifically hold a certification do describe that. They have their primary licensure or some specialization evidence to help support that. However, we strongly encourage that those individuals working as diabetes care and education specialists do have a certification, because this is really how you, your employers, the people that you're working with diabetes have evidence that you have reached this level of competency. So having the CDE or BCADM are two excellent ways to demonstrate this. There may be some other certification that really clearly supports your title as a diabetes care and education specialist. So I hope that answers that question. And again, we appreciate Cheryl Traficano and some of the board members from NCBDE's participation in this whole process, because it is so important that we do have those questions clarified and that people do know what the expectation is. Thank you.
Okay, the next question we have, it says, what is the best way to present this title to our employers and have them recognize the expanded role and value?
And this is Chuck McFarland, and I would say having that conversation is important, but doing it in a very deliberate way and one which emphasizes the focus and value that you bring to the table is the most important. AADE will be putting together an entire toolkit to provide our members to have those conversations, not only with your employer, but with providers as well as patients. I would say sit tight for a while. If you have a very good and comfortable relationship, you may begin to have that conversation now, but just know that probably later this year, towards the end of the year, we'll be providing some specific information and language for you to use.
Great, thanks, Chuck. We have a few questions asking if AADE will be changing its name.
So we are in the process of evaluating that. We continue to work with the brand consultancy to see what is best. I think that this highlights something that we haven't said. None of this was taken lightly. This is a huge step. Changing the name of the specialty is a huge step. The consideration of changing the organization's name is huge. And it would only be done with such clear evidence that supports the benefits. So as you saw in those data that Jen presented, there was incredibly strong evidence to support the change of the title. And we will continue with this research, and by the beginning of the year, we will be able to present that research and keep you up to date on that change.
Great, thanks, Karen. We have a few questions about this, and I'll direct this one to Cheryl. And some people are asking if they'll be using CDE and DCES in their title.
Well, thank you for that question. Well, I mean, normally people, as diabetes educators, aren't using that as a credential or an acronym. You describe your job title. You say you're a diabetes educator or a diabetes care and education specialist. So you'd continue at this point to still use your CDE as part of your credentials, and your job title is a separate listing. So, and again, as I stated earlier, we're investigating the implications of that, and there may be a change to the name or the designation of the certification, but we're still investigating that. But it's still DCES wouldn't normally be used because you don't normally identify your job title as an acronym. So hope that's helpful.
And so on my signature line in the way I'm introducing myself, I would certainly say Karen Chemist, and then my license, my healthcare license, PTRN, the academic degrees earned, and any credentials, including my CDE, go as initials across at the end of my name. Underneath that, in more of a descriptor line, I would write out the words diabetes care and education specialist. So it's really, as I just said, a descriptor of a specialty. But I would not put that within those initials above that are specific credentials.
I would just add, this is Chuck, that I think there's an opportunity within this change to clear up some perhaps confusion within the field. Often many audiences talk about diabetes educators and use the term CDE. They are not interchangeable. Not all diabetes educators hold the CDE credential. So I think it is an opportunity for us to make that clear.
Great, thank you all. The next question, Karen, it says, will this change be communicated to insurance companies for contracting purposes?
We will have that as part of the toolkit, and that's, CMS, the Centers for Medicare and Medicaid, certainly guide a lot of that. So we will be working with CMS just to help describe what we do and to realize that there's much more than diabetes self-management training that we are involved in. So as time goes on, hopefully we will try to drive some change. The other thing we're doing is we have a committee working specifically looking at advocacy on reimbursement, and we'll have that information available probably in the early part of next year. Another somewhat of a toolkit to be able to say, here are all these opportunities for billing and different reimbursement models so that we can really capitalize on what we do. Because there's so much more than PSMT billing, and that really doesn't look at the future with all the different care models that are coming out. So we need to make sure that we get that information to each of you as individuals so that that can be addressed on an individual basis also.
Thanks, Karen. The next question says, how does this affect diabetes paraprofessionals?
So some paraprofessionals would have a way of having a specialty in this area, so they could include themselves as a specialist, and that would be on an individual basis. So some, and that's one of the groups that still might act as a diabetes care team member without having the CDE or BCADM because they wouldn't fit the criteria to take the test. So that would present as an opportunity, but again, it would be a descriptor. Primarily, the person would need to say what their, what gives them the, let me use as an example, an LPN. We would have the person use their name and LPN as their license, and then the next title is a descriptor. But it is so important that we use our credentials first and foremost because that's what individuals are coming to see us related to.
Great, thank you, Karen. The next question we have says, how will this impact the competencies for diabetes educators and diabetes paraprofessionals and the diabetes educator practice levels?
So we have a committee working right now. They started in July, had a face-to-face meeting during AADE 19 in Houston, and are heavily into this work. This is a great opportunity to relook at the levels and competencies in the descriptions of the practice. And I've been exposed to a little teeny bit of the work so far, and it's really exciting how the product that will come out in the end will give us much flexibility. As a brief example, a particular diabetes care and education specialist might have an incredible specialty in technology, but not have as much of a level of competence in behavioral health. In the past, our competencies and practice levels really packaged people as if you're an expert at one level, or you're, had moderate knowledge in one level or lower levels of knowledge. There will be a way to cross over depending on the particular category to find your niche and to look for educational opportunities to progress in different areas. So I'm going to put a timeline on this. I think by the middle of next year, we should have the levels and competencies ready to go, and I hope you'll find it really helpful to be able to individualize and potentially look at areas to improve your knowledge and competence in. So keep your eyes out for that.
Thank you, Karen. Another question we have says, is there a plan to clarify, especially with referring providers, the identity of our profession as being multidisciplinary? We still find that most providers assume educators are nurses, and they tell patients they're being referred to both the diabetes nurse educator and the dietitian. It turns out that our facility, the educator and the dietitian, are the same person.
And I might jump in quickly on this one. As Karen mentioned, as soon as we had announced this at our annual meeting, our next step was to hold a stakeholder summit at AADE 19 with a variety of provider groups. And I think this provides us an opportunity to clarify both the focus and who is engaged in the specialty. It won't be perfect, and I think that's a lift that we have to do both at a national and local level. Quite frankly, you might have the best impact doing that directly. And because there are so many models of providing diabetes care and education, that I think that the more that we are doing, the better. But again, it gives us an opportunity to really do some clarifying within our messaging around this change.
All right, thanks, Chuck. Another question we have, Karen, it says, have you seen other organizations do a similar rebranding?
Yes, when we first started our vision work back in 2017, the professional consultants we worked with on that had what I thought was an excellent example of this. They had done work with what was originally the National Hospice Organization, and that organization felt like that title limited them because one key area that they worked in was palliative care. And again, you don't take any rebranding or retitling lightly. There's a lot involved. But they really determined that it was best for their organization and for their members and for people who access their services, and changed their name to National Hospice and Palliative Care Organization. Another one that's come up recently is ostomy nurses went to wound, ostomy, and continence nurses, because with just ostomy nurses, people aren't necessarily looking to work with an individual for wound care, continence care. So the society, the organization is the Wound, Ostomy, and Continence Nurses Society, and they have a certification similar to our CDE. It's the Certified Wound, Ostomy, and Continence Nursing. So I think those are two really good examples. I was thinking as I was preparing for this, the Juvenile Diabetes Research Foundation found that that was limiting a few years ago, and they rebranded to JDRF. It was too limiting. So many people with type 1 diabetes have progressed into adulthood, and it really limited the idea that an adult would go to that group for assistance. So, I think those are three good ones. And again, these are big steps, but I think each of these groups really put a lot of thought into the process and came out with these changes. And there's probably lots of other good examples, but I think those are three that really kind of hit home.
Thanks, Karen. Karen, another question we have is, what feedback have you received from members to date on this change?
So as I mentioned earlier, when I was on stage and I got to announce this, I think the board and the staff and those engaged in the process were really excited because we knew that the data pointed us in this direction, but we also knew that this was going to be big and different, and change can be challenging. I was overwhelmed when I said the words on stage, and I kind of asked the board members in advance, you guys be sure to clap. It was so crystal clear that the cheers and the clapping resounded from all areas of the 3,000 attendees. So we were really excited at that point. Not to say that everybody, was super excited about it and there weren't concerns, but I think as we continue to hear the concerns, almost all of them relate to what does this do with the CDE. So we keep driving home, and I hope all of you on the call can continue to clarify to everybody that the CDE is that great credential that supports competency as a diabetes care and education specialist. Because that's a sticky area. I'm so proud of my CDE. I'm so proud that I'm a diabetes care and education specialist. And again, at that Stakeholder Summit, that was we literally met that afternoon after I made the announcement. So the group wasn't exposed to this for the most part. nothing but positive. Really exciting. So we continue to have conversations. We do want to hear from you. We understand that there will be reservations, and I think we want to, I know we want to address those. I think some we just really need to put the data forth. And actually, as I say that, when I first gave the title, I didn't present any of the supporting data. At the business meeting a couple days later, Chuck went through those data, and that really turned things around for people. Then they felt so much more comfortable with this change because it's so clearly supported from the data. When we work with individuals with diabetes, we provide evidence-based care. Not having been through a process like this before, I was not aware of all the research that went into it, and it really parallels what we do in our healthcare professions. The research, the process that the brand consultancy brought us through was, just such an eye-opener, and it just gave us the confidence to move forward with this big change.
Thank you, Karen. Cheryl, this question would be directed to you, and it says, if there are changes to the CDE exam, when do you think the changes will happen to the exam?
So thanks for that question, too. So we actually recently just completed a practice analysis in 2018 and put into place changes to the exam content outline just this July. So in the past, we had been doing practice analysis every 5 years. And what we will be looking at is, rather than waiting 5 years, is we may do it in 3 years. So we can assess what's happening in the field. If things are happening quickly, we want to make sure that the exam content can relate to that. But then again, it would be like in that 4th year that any change to the exam content outline would happen. So we always give, quite a bit of notice and updates once, things change with the exam.
Great, thank you. And I think, Cheryl, this next question might be directed at you as well, and it's 2 parts. And it says, many people use the title Diabetes Educator without the certification of CDE. If I can use the title, is there a reason to get certification? And will this new title hold anything more defining to limit the use without the training that we use to become a CDE?
Okay, so I think this ties into something Chuck might have alluded to, or not alluded to, he talked about earlier, and that people often confuse just the term diabetes educator, which originally was a job title or a description, with an actual certification. And so someone could always have called themselves a diabetes educator. They couldn't use CDE as an acronym after their name or identify themselves as certified. So that has always been the case. It's just that luckily CDE is so well known, people realize that when people have achieved that, they've really stepped up to the plate and been able to verify their level of knowledge. And I'm not sure about the second part of that question. I mean, it'll basically still be the same situation. It's like people will, until they show that they are certified and can use that, credential, then they still have not, they can use any descriptor of what they're doing, but there's no verification of that knowledge or the skills related to that without, taking the step to be certified.
And I'll just add to what Cheryl, oh, go ahead, Karen.
With that, I really encourage all of us to be sure to have CDE after our name if we have that, and BCADN the same thing. It is so important to referring providers and the people we work with who have diabetes to see that we've achieved that credential. It is, it really does demonstrate our competence in this area, so please always be sure to include that with your materials and introductions and as part of the referral process.
And the only piece I will add is, while AADE has always encouraged diabetes educators to seek out the CDE credential, I think changing the name to Diabetes Care and Education Specialist only adds more emphasis to that encouragement. If we're defining ourselves as specialists, the more that we can demonstrate that we have specific knowledge, skills in a particular area, the better that we will be able to serve, all of our audiences.
Great, thank you all. Karen, how would you recommend we work with our fellow diabetes educators who might be resistant to the change?
Well, I think understanding what has supported the change is really helpful. So to hopefully share those data that Jen presented and how strong this new term is as far as people with diabetes appreciating it, referring providers, and other stakeholders. So to really feel confident that this is the way to go. We certainly can't force anybody to do anything, but this does nothing but elevate their practice and really describes better what we do. I mean, if we look at it, we kept diabetes in education. Diabetes will always be at the cornerstone of, you know, as far as our treatment, people we work with. Education is one major method. It's an intervention. It's one thing that we use. Including the care component really best describes what we do when we meet with an individual or in a group format. You know, we go through an assessment process. We determine with the individual what their goals are. From that, an intervention plan that's created with part of that being education. Then we continue on with further evaluation and ongoing care. That's the whole care process with education being part of it. And then declaring that we're specialists, you saw in the data how much that elevated the confidence. I was so pleased during the business meeting when we had question and answer. One young lady came up and she said that she has type 1 diabetes, and she was just, the new title really resounded with her. She said, in the past, it's been fine working with a diabetes educator. When I see this, I feel like I'm really going to get great care from a specialist. So, I hope that people will want to use it to really describe what we do and all the benefits we can provide. I think it describes the service far better than diabetes educator alone. And if somebody's resistant, then that's their prerogative.
And I would also add to this, to level set expectations. Any rebranding, whether it be to an organization or a specialty, is a multi-year, maybe multi-decade process. This will not change overnight. We will see at some point a tipping point, and at that tipping point, those that are using old terminology will be appear to be irrelevant, and so we will move beyond that. But this will take a long period of time. We'll be doing rollout activities for the next several years. Next year, we will probably be encouraging all of our coordinating bodies and LNGs to be doing a presentation specifically to this. It'll take us a while to reach many audiences. Today on the phone, we have 305 people. That's good for a webinar. It does not represent the other 13,000 diabetes educators that are out there that still do not have this information. So this will be a long-term process, and we'll call on each of you to help carry that water.
Wonderful. Thank you. Jen, I'm going to direct the next question to you, and it says, were current CDEs asked about the change via survey prior to the name change?
They were asked within that quantitative survey, so we had a good representation of current CDEs. And as part of that survey, we got both perspectives. So we got the perspective on how the current name of diabetes educator, or the current specialty title, compared to the others that we tested. We did not do a separate survey initially to put us into this process, but they were included throughout the process.
Thank you, Jen. We have another question here. It says, with these changes, is there a national marketing plan that will help inform the public of our services? And I'm going to throw that to Chuck.
And I will say, yes, we are in the process of working through our internal stakeholder communication, and then there will be plans around each of our primary audiences. As you all know, reaching the general public with a set of messages is very challenging, but we'll have a number of media outreach and even began to get some of that at the annual meeting as word began to spread. We won't be able to do advertising as much as perhaps Amazon, or FedEx, or I don't know why those are coming to mind, but we will do our best, and we'll call on you to carry that water in your local markets as well.
We've already had some some really nice articles written from the meeting, from some of the organizations that work with people with diabetes and like some of the endocrine-based publications. So that's a nice starting point. And, you know, with social media the way it is, that's a great way to really expand the reach. So if you all use your sources and keep an eye on some of these other groups. But people are excited about it, so hopefully the word spreads. And you know, we do have to be realistic about that, but it's an exciting venture.
Great, thank you. And we're going to take one final question here that I will ask Chuck, and then Karen will have you take it from there. But Chuck, are there plans to monitor the impact of this name change on our profession?
So I would say yes, absolutely. You've seen a portion of the data that the brand consultancy generated for us. There was a whole series of other data that looked at our existing brand strength and reach. And I believe that we will be putting together kind of a set of measures to look at how this name change impacts that. That goes to our brand, but I think it also will go to things like utilization and understanding. You know, we now have a good level set of what various audiences understand a diabetes care and education specialist to be, and we'll be looking at if we carry that forward to utilization.
Okay, Karen, do you have any final remarks before we close?
I really want to thank everybody for participating. Like Chuck said, we had well over 300 people on this call, and I know it's probably the middle of your work days. It really shows your interest and your passion. Please keep the conversations open. It's exciting. We know there are some reservations and questions, and we really want to be here to answer them. So thank you for your time, your interest, and all that you do for your organization, your peers, and most importantly for people with diabetes. And I hope you have a great rest of the day.
Great, thank you. We want to thank Karen Chemist, Chuck McFarlane, Cheryl Trafficano, and Jen Layton for being here today and presenting and answering all your questions. We had a number of questions about the webinar if it's being recorded, so that recording will be posted on the website and everyone will receive an email when it's available. As a reminder, if you have any more questions, you can email them to aadevision@aadenet.org. Thank you all. This concludes today's presentation.